What I'd like to speak with you today about, and the topic that was chosen, is the surgery for the posterior maxilla. Now, just for the record, I do like working in the entire mouth, but I do spend a quarter of my time in the posterior aspect. So just make that known. What are the consideration challenges in the posterior maxilla? This is going to be a sort of a review of things that we should know about. Certainly, sinus pneumatization is a key factor and expected after effect of loss of teeth. Crestal bone loss from either lesions or periodontal disease. A lot of times we end up with combination resorption, in which we lose vertical bone, both, and also horizontal bone, as well as working in D3, D4 bone, which is very characteristic of the posterior maxilla. And of course, we have increased occlusal load, which we have to consider in our treatment planning. So what are the objectives that I consider whenever I treatment plan any type of implant case? This is not just for posterior maxilla, but in any type of a mouth. My objective is to create functional restorations. Very, very simple. I want them to look great. I want them to be aesthetic. I want them to be biologically compatible restorations. I want them to be easily maintainable, cleansable, and well maintained by the patients. And also keep it as stable and as long-lived as possible. If these are my objectives, then there are some factors that I think is important to optimize. And if we kind of focus on the posterior maxilla, these include optimizing the bone quality, the bone quantity, the implant stability, the implant position, as well as where the platform is, and also the architecture and the biotype from the soft tissue standpoint. So everything that I'm going to be talking about is really to support those objectives. Because we know that when these parameters are not suspected, we have complications. And we see a lot of complications, which I think is going to be the next phase in implant dentistry, is dealing with a lot of complications from things that we haven't done before, and now we're starting to learn. Like this patient who had chronic pain for almost 3 years around these implants, and nobody could figure out why. And when she first presented, it obviously presented with a very highly apically positioned implants, very difficult to access for hygiene. And when we look at the x-ray, the implant platform was clearly up more apical than where the interseptal bone was. The implants were basically placed where the bone was, and this is what we did for many years. In addition to that, we take a CBCT and we see that the implants are perforated into sinus, and also there is no bone on the buccal aspect of the anterior implant. Peri-implantitis, pain. This is a very characteristic picture that we see, and this is what she had. Unfortunately, there is no great treatment for this, and we'll talk about what we did with her. How about this patient? Just came to me last week, a patient who had an extraction, immediate placement of an implant, and she asked me what I thought of it. Apically positioned by almost 6 to 7 millimeters apical to the interseptal bone, and I told her I think this is grounds for disaster that's going to happen. Once it's restored, losing bone, access for hygiene, peri-implantitis, I think we can kind of see where that goes. So today, in discussion of the posterior maxilla, I'm going to run through several relevant topics. First, starting by extraction. Let's get back to the basics. Atraumatic extraction. Doing it in a way that we can preserve the bone that we have. And doing site graft. Certainly very effective in augmenting and preserving the ridge, so that when we place the implant later on, we can place it ideally. Of course, the key benefits from standpoint of the bone preservation, site graft is bone preservation, bone augmentation, and also probably minimize sinus pneumatization, which is something that we expect to see. In a study that was written by John Thousand, he looked at the number of patients and looked at the volumetric changes in the grafted and the non-grafted when it came to the sinus pneumatization. And basically his conclusion was that the ridge preservation might reduce the sinus pneumatization after a tooth extraction, and that these changes can be mitigated but not entirely eliminated by grafting. So we have to kind of be cautious about using the grafting to minimize the sinus pneumatization. It may not work as well as we used to think. Another great evolving aspect of extraction is the socket shield partial extraction therapy. And this is a courtesy of my good friend, Dr. Manuel de la Rosa, who performed this on a molar. Most of the cases reported in the anterior teeth, fewer cases reported in the posterior teeth, but very much following the same principles. We're leaving a shell of the root aspect, placement of the immediate implant, and he beautifully was able to graft and preserve the tissue. And once the tissue is restored, the soft tissue and the bones maintained beautifully. So I think this is an exciting, evolving technique, which I'd like to develop my skill set at it too in the coming years. How about extraction and management of perforation, sinus perforation? Do we get it? Absolutely. Can we predict it? Absolutely. Here's a patient that had the extraction of tooth number 3 planned because of a vertical fracture from an endodontic. And right away we can see that there is a silhouette, there is the scalloping of the sinus floor. When I see that on a periapical x-ray, right away I get a CBCT because we have to know exactly where the root tip is and be able to diagnose and plan this extraction in advance. I'd rather tell the patient in advance that we're going to anticipate a perforation, that we need to do certain kind of grafting, rather than being surprised by it. And the patient will be surprised by it too. So here we are, we can see the CBCT where the root perforation after extraction is almost guaranteed. We know it's going to happen. In fact, the tooth was removed very traumatically, and right away we can see those black holes going right through it. What do we do? Why graft it? I think there's 3 good reasons to consider grafting. Certainly bone preservation, certainly to prevent the oral-antral communication, but also if there's a larger perforation, we can minimize formation of OAF, oral-antral fistula. So these are all the good reasons to graft it. How do we do this? It's a concept called the 3-layer site graft. The first part of this procedure is a sinus level membrane. Whether you use a collagen material or a membrane, we're going to plug the sinus level. Second stage is bone level grafting with a particular bone graft. Next, we put a gingival level membrane, and then we put some sutures to stabilize the entire complex. And 4 months later, we would expect to see a fantastic, incredible amount of height of bone, but we don't. We have 2.3. So we did crestal bone preservation, but no socket bone preservation. Why? Because the scalloping effect of the site was a predictor of why this is going to happen. Another patient, pretty tall root, a sort of a sinus floor that comes down not as low, kind of midway. After the extraction of the site graft, we come back in about 4 months, we have 4 millimeters of bone. By the way, if you take a periapical x-ray, it'll lie to you. It'll show you that you have plenty of bone, but it's not there. So I think that through what I've noticed is that there's a questionable effectiveness of site graft in preserving the height of the bone when we see that type of scalloping sinus biotype. So that's kind of a little bit of a red flag. If you see it, the results are not going to be as great. Let's talk about site conversion, another important aspect of treatment in the posterior maxilla, because we know we have D4, D3, D4 bone, and also when we do sinus lift or bone grafting, most likely after a 6 to 7 month period, we have a D3, D4 bone. So how can we go ahead and convert this to a D1 and D2? Once we convert it, if we're able to, that will probably provide us with a better implant stability and perhaps even a better integration. So we do that with osteodensification technique. Osteodensification is not a new concept. It's been around for a very long time, and we have used the various types of osteotomes to be able to perform this. And of course, now we use more of the rotary technique, which we'll demonstrate. And this was a study that was done by Tracy and Berendini that looked at the conventional implant group and also versus the osteodensification group in sheep. And he did demonstrate that there was increased density and mineralization in the test group. And this is being demonstrated in a number of other studies that are coming out. He also showed that there was the 30% higher percentage of bone volume or density in the densification group, and that there is a better removal torque, increased primary and secondary implant stability, and these all kind of support what we had suspected. So certainly a very effective strategy. Here's a demonstration of a case of a patient who presented with advanced periimplantitis, bone loss of an implant, which was removed. The defect was immediately grafted using the particulate graft complex and using routine GBR technique, using our PRGF to cover the bone graft and primary closure. We come back in about 6 months and we have a fantastic augmentation and preservation of the bone, and we have quite a bit of bone to work with, but I think this bone is softer bone. It's more of a D3, D4 bone. And you can always tell because when you put the drill in there and start drilling, you feel that there is absolutely no sort of friction as much as you would expect. And this is kind of how it looks on a CT scan. So now in preparation for our implant, we're going to go through our standard computer-assisted planning and workup, create our surgical guide, and we're going to start with preparing the site, not with a routine drill, but with the osteoidentification rotary instrument, which we use in reverse mode, 800 to 1,000 RPM, in increasingly wider diameter. And I'm essentially taking the bone and expanding it out and densifying it in the process. And then finally, we can go ahead and put the implant. You'll notice that when you put the implant, once it's densified, it's quite tight. In fact, a lot of times you have to use your hand wrench to be able to rotate that implant in. And remember, this is grafted bone. It's D3, D4 bone, and yet it requires a very good amount of force to be able to place that implant. And of course, we'll go ahead and put our soft tissue graft, connective tissue graft, because we want to augment the soft tissue as much as possible. And then about 3 months later, it's uncovered and restored, aside from the poorly contoured restoration, which I complained about and it's being redone. The case worked out quite well. Let's talk about sinus lift, which is really kind of a workhorse of one of the procedures most commonly done in the posterior maxilla. First, let's talk about what the keys to success in sinus lift is. And I think it's important to realize that when we have a healthy sinus and a healthy membrane, and also intact while it's being lifted, with a proper bone graft and hopefully avoiding infection, usually we have a very good success rate. In fact, it has a very predictable success rate. And this has been shown in studies and experience for several decades now. So what contributes to sinus lift complications, and this is what we can avoid, is certainly treating patients with sinusitis. If they have a pseudocyst, it can potentially compromise the outcome. Smoking, poor membrane integrity, presence of a septum, which can complicate the sinus lift because of tearing, and of course, operator error. And it's important to have good training, good techniques to do it properly. There are several decisions that I always have to make whenever I'm dealing with a sinus lift. The first decision I got to make is which surgical approach to use. Second is, what's the best bone graft material? Third, am I going to do this in a 1-stage or a 2-stage? And lastly, if a perforation happens, what am I going to do? So these are the 4 key questions and decisions we got to make. The surgical procedures or the approaches that we have available is really 2. There's a lateral approach, the window approach, osteotomy technique, or using the transcrestal approach, which we have the osteotome or Summers, which has been around for a while, the crestal core elevation, osteodensification, and the balloon technique. So let's talk about the lateral window osteotomy, which really known as a direct sinus lift procedure. And in my experience, it may be the procedure of choice if I'm desiring 5 millimeters or more of augmentation. Not that it cannot be done with osteodensification or other techniques, but maybe more predictably, I can use a lateral window. And there may be a decreased risk of membrane perforation because we have a direct vision, direct handling of the membrane. Let's go over this case. Patient who presents with an advanced lesion of tooth number 3 with loss of bone and perforation into the sinus. So we have really a missing structure 3-dimensionally. And this is going to be a staged treatment, 1 miracle at a time. The first is extraction of a tooth atraumatically. Right away, we notice the perforation. We're going to do a 3-layer closure to obliterate or at least block the sinus floor. We'll go ahead and pack our bone particulate to restore both the lateral aspect as well as the apical aspect and try to augment the site as much as possible. collagen membrane, PRGF membrane, and we're going to just kind of close this primarily and let this settle in probably for a good 5 to 6 months. In 5 months, I come back, and we have 4 to 5 millimeters of bone. Again, the same thing that we expected before. The sinus perforation, it's going to come down, it's going to pneumatize. Well, with 4 or 5 millimeters, I can do a single stage implant placement and sinus lift, very predictably. We'll go through our conventional CAD/CAM design, computer-assisted treatment planning, choosing ideal size, diameter, and length implants, ideal occlusion, ideal wax up. Every case I do now is 100% digitally work up, similar to these. And now we can go ahead and sort of re-expose our site. We see that we have a fairly good ridge to work with in terms of its height and its width. So really all we need to do is a simple sinus lift to provide us the safety zone for placement of the desired implants. Here I'm going to use a combination bone graft, and I'll describe to you my technique for how I use the bone graft and what sort of combination. The initial drilling is done, and you notice that I go ahead and use the osteodensification in placement of the implants, because it's critical to have that primary stability of the implant if you're doing a single stage placement, and doing the osteodensification helps greatly to do that. We'll go ahead and place our implant, pack in our bone graft. This is the sticky bone, and I go ahead and top it with some inorganic bovine bone, covered with a dissolvable membrane, and then finally put some PRF membranes, which is fantastic for soft tissue maturation and healing of the site, and close it up. And this is about a month later. We can see the abundance of apical and lateral bone, and we are set for success in absence of infection. This is a case that's going to withstand the longevity that we're looking for. And the transcrestal approach is known as the indirect approach, and to me, it's a technique that I can use when I'm planning on doing 5 millimeters or less of bone augmentation in a vertical direction. And of course, you have to be cautious because this is a blind technique, so there's potentially a higher risk of perforation. It works really well when the membrane is thick, and when the membrane is thin, of course, we could have a complication, and there's no way to measure the membrane, at least predictably. So osteoidentification is really the technique that I've chosen to be able to do the transcrestal approach. Here's an example of a patient which presents about 7.5 millimeters of height of bone, and my plan is to put a 10 millimeter wide diameter implant, in which case I would need about 4.5 millimeters of additional bone, because I want 2 millimeters of bone in excess apical to my implant. So we need about almost 4.5. And the technique is, as demonstrated earlier, is using our guide and really using our osteodensification to not only expand the bone, but now we're trying to push the bone more apically. And we use this technique where essentially you're pumping up and down the osteodensification burr. And once the level has been reached, we can take some particular bone graft material, and very gently we can sort of pack it inside. We put the burr back in reverse mode, and essentially it pushes the bone and gradually lifts the membrane until we're ready to place our implants. And these are quite stable. We can put in a healing abutment at the same time. And here's the PA, which shows the bone where it is. But to me, the real way to see what we've done is the CBCT. And that's what we did. We see that we did achieve the elevation, and we had about 11 millimeters of bone, which was 1 millimeter less than what we had planned, but quite successful in achieving the lift that we had anticipated. And this is how it was restored and worked out quite well. The next question is, what kind of bone graft material do we use? Autogenous, substitute, combination? And we have biological factors that, of course, we use in combination. A study that was done by Klinge and Meyer, they took a whole bunch of articles that have been written on this topic and selected 64 of them that really kind of looked at the autogenous bone and the alternative bone graft material. And they looked at the success of autogenous bone, whether the delayed implant placement, the substitutes, placement of membrane, and they sort of really came up with the conclusion that the autogenous bone was a gold standard and produced the most volume of bone. The bone substitutes showed less volume of bone, and the immediate placement resulted in higher total bone volume. And they did conclude that the total bone volume does not necessarily result in higher implant success rate. Okay, a fair statement. So this was a study that supported it. Another paper by Kinke that looked at a number of different literatures and really asked the question, is autogenous bone superior to bone substitutes when it comes to sinus floor augmentation? And basically, when they look at all the evidence, they said, well, the evidence neither supports nor refutes the superiority of autogenous bone graft. But I think that with autogenous bone graft and knowing all the biological benefits that it carries does have a huge amount of benefit in any kind of bone grafting, including sinus lift. So what is our protocol? This is a protocol that I've been following for years, is essentially using a combination of this. And this is kind of what I call the layered strawberry cake technique. Sounds a little bit more delicious. How do I do this? The layered strawberry cake to me is sort of essentially segmentalizing the bone grafting into 3 different layers. The zone 1 is the peri-implant, where I use about 75% autogenous bone and 25% of the mineralized freeze-dry bone, and I call that the cake. That's like the bulk of where I need the great bone and osteogenic potential. The next layer is the zone 2, where I call beyond implant, and I use about 25% of the autogenous bone and 75% of the mineralized freeze-dry bone, and I call that the fluff. And the last layer is the zone 3, the lateral wall. I just use 100% of inorganic bovine bone, and I'll call that the icing. It makes it look great. And of course, I use the resorbable collagen membrane on the lateral wall, even though the studies show that it's not necessarily advantageous, but it is part of my procedure. I use a sticky bone for soft tissue maturation. So here's our bone combination in this case, basically segmentalizing the autogenous bone that was harvested from the ramus, and I just kind of divide it into those proportions. Here's our sticky bone, the cake, the fluff, and the icing. And now we go ahead and proceed with a conventional incision, crestal incision, using the piezo to create our lateral window, taking care to make sure the membrane is intact. It's the most crucial part of the procedure. If the membrane is torn, which we'll talk about later, could potentially cause some issues. So we have our sticky bones ready. We'll go ahead and do some osteodensification. We go ahead and place the implant, but not all the way. I place the implant about halfway because I'm going to do some bone graft in the sinus, and I want to make sure that I don't have any voids medial to the implant. So I'll just place it halfway. I place the initial cake part of the grafting, which is the zone 1, and then the implant is rotated into position, just to make sure that we don't have any voids from not being able to pack the bone graft completely on the medial aspect. The zone 2 goes in, the zone 3 goes in with the inorganic bone, and we cover that with some membrane and some PRF membranes and close the tissue. We like to have a tensionless closure, a little bit of a periosteal scoring, and then let this heal for about 6 to 7 months before the uncovering. Next question is single or two-stage surgery? I think it's rather a simple question to answer. If I have minimum of 4 millimeters, a single stage can be entertained. And of course, with the advent of osteodensification and getting that primary stability on the implant, we can do it more predictably. How about perforations? I'm going to talk about the 3 types of perforations that are probably seen most often, the class 1, class 2, and class 3. First of all, perforations can happen if the membrane is thin, also if there is a sinus septa, and certainly from iatrogenic reasons. A study that was done by Lum and Ogata, they looked at 167 patients and 47 of them with perforations. Interesting, they noted that the group that had the perforations incidentally had mean membrane thickness and ridge thickness much lower than the non-perforation group. So I think that is a very critical factor in predicting the perforation in any patient. In a class 1 or class 2, where we have less than a 2 millimeter or 2 to 5 millimeters, typically it's possible to continue with the elevation, fold the membrane upon itself, and plug it with a resorbable membrane, and typically a favorable outcome can be achieved. In a class 3, where there is a complete tear, basically you must abort the procedure. There's no way to fix it. Cannot attempt it, cannot put in a membrane. Any kind of bone graft material is going to fall all over the sinus, and it will not work. So abort, antibiotics, let it heal for about 3 to 4 weeks, and then upon re-entry, we do want to do a split thickness flap and push that tissue up. As I said, immediate repair and grafting is unfavorable. So essentially, you come back in about 4 to 6 weeks later, we have a soft tissue that can be elevated, and essentially it becomes the new roof of the sinus, and the procedure can be completed successfully at that point. Let's talk about some defects, what I call bidirectional double arch posterior maxillary defects. This is a very common, sort of a very common type of a deformity that I see often, and this is when we have both a defect from a sinus standpoint, in addition to vertical, and sinus as well as horizontal. So there's 2 forms of this bidirectional defects that I see quite often. So if you kind of go back to our original objectives, and the reason is, why do we do these type of surgeries? They're not simple, they're not cheap, they are certainly hard for patients. There's got to be a good rationale to impose patients to these type of procedures. And I always go back to the objectives that I had. If I want to kind of meet those objectives, then I must be able to improve the quality of bone, the amount of bone, the soft tissue, the implant stability, and the platform. So these surgical techniques that I'm going to describe to you is designed to accomplish this. And you may say to yourself, as you see some of the cases, that, you know, I could have placed an implant there. You didn't need to do all that. And the answer is yes, absolutely. I could have placed an implant where the bone was. But I think we have to learn from these errors, these mistakes, and from these lessons that immediately it's going to look great. It's going to look fantastic. Talk to me about 5 years, about 10 years, about 15 years down the line, like the patient that I showed you, and see, can the patient maintain it clean? And if they can't, peri-implantitis is inevitable. So it's not a question of being able to put an implant because you can and because it's easier or because it's cheaper. Let's go back to what's more predictable in the long term. So that's a very important question to ask. Let's talk about this case where we have a bidirectional augmentation in a vertical defect, a combination of sinus lift from what I refer to as a Corey graft technique. A patient that basically presented with a large defect from a periodontal disease, and that tooth was extracted. We end up with a vertical bone loss, a pneumatose sinus. We have about 3 to 4 millimeters of bone height, and essentially what I refer to as a double arch posterior maxillary vertical defect. What are our options? Can we just do a sinus lift? Of course, but that's going to put our restoration platform way up there. It's very difficult to maintain clean, hygiene access may be an issue. Can we just do a ridge augmentation? We probably could, and maybe use short and wide implants. That is a possibility, but I want to kind of maximize the biomechanics of maybe a longer implant, maybe increase the bone contact in the posterior maxilla, D3, D4 bone. So I'm going to over-engineer a little bit. So perhaps we can do this where we can develop, augment the ridge side and the sinus side, be able to put our implants in more ideal position and the outcome. And we have several options of how to do the ridge grafting. We could do an onlay, intrapositional, GBR, or we could do a block shell and GBR, and that's the one that I chose particularly for this patient. And this is because I had great bone in the interseptal area in the anterior and great bone in the posterior aspect. It's a great ideal case to bridge them together using a shell of bone harvested from the ramus. This bone can be thinned out, and essentially we just put a couple of screws, fixate it, and create a space. We'll go ahead and create our autogenous bone particulate, pack it into the area, cover it with membrane, close, and let it heal for about 6 months. And we can right away see that we have a more enhanced vertical level of the tissue, and we look at the amount of bone that we were able to produce. And here's kind of the comparison, going from here to here, using a single stage technique to augment both directions. We'll go ahead and remove our retaining screws. We can appreciate the wide and tall dimensions of the bone, place our wide diameter implants, ideally with adequate bone and the buccal aspect, which is also very important in preserving the implant in a healthy state. And here we are with the implants uncovered, going from there to there, final restoration, and this is the kind of outcome that we can be proud of. I think this is a very stable case. Thick tissue, thick bone, wide, tall implants, restoration well designed, easily accessible for hygiene. Every bit of the procedures that we did, well worth it. Let's look at another case, another patient with a vertical defect. And I'm going to describe another way to do this. So similarly, missing posterior teeth, big vertical defect. Good horizontal, a little bit of a soft tissue deficiency. And this is what we have. We have deficiency in the sinus and the vertical aspect. A little bit of a knife edge in one side, a good broad ridge in the anterior to it. And essentially the point is, can we go ahead and do our sinus lift, and can we correct this defect so we can put our implants more in ideal alignment with the rest of the teeth? And we'll have the same choices of several different types of techniques to use. So we'll go ahead and use what's called a segmental osteotomy with an interpositional graft. I'm going to describe how this is done. The first step is we do a vestibular incision, not a crestal incision, because our only point at this point is to do a sinus lift. And also we're going to do a segmental osteotomy. So the incision has to be positioned in the vestibular aspect. So we'll go ahead and do our sinus lift. Number 2, we'll go ahead and do our segmental osteotomy. We'll take our piezo and create a standard osteotomy in the anterior, posterior, and also on the medial aspect where it meets the palate. We want to mobilize this segment. Number 3, we're going to inferiorly reposition the segment. So with our osteotome, once the bone is mobilized, we can easily push it down inferiorly and really see the change in the level of the bone as it happens. Number 4, rigid fixation. We'll take a basic titanium plate. We're going to hold our segment down in the new position. We're going to fixate it with 6 screws. Pretty solid, it's not going to move. Rigid fixation is a requirement for any kind of bone healing, and this is quite stable. So the components of this technique is inferiorly positioned segmental osteotomy, interpositional block graft we're going to put here for stability. We're going to put some sinus lift, particulate bone graft here and here, and we have rigid fixation. And this is how it's designed. So we'll go ahead and do the bone graft. We have a block graft that we're going to put in the step just to provide the posterior segment stability. And we'll go ahead and pack the bone into the remainder of the defect using our sticky bone, topped by our icing, the inorganic bovine bone, and closed primarily. And we'll come back 6 months later and we have this type of outcome. Predictable, restored, back to the interseptal level along with the other teeth, and certainly adequate width and height to be able to ideally position our implants. Going from to here, much more ideal outcome and environment. We'll go ahead through our standard, computer-assisted planning. We want ideal restorations, and ideal positioner implants. And I think you can kind of see that here's the restoration. Here's the height of restoration. Here's the gingival margin. And now we have an ideal runtime between the platform and the restoration on both sides. This implant is ideally located from a vertical standpoint. Our guide in position again. Standard crestal incision. We have to create a little bit of a larger flap to remove our plate. And we can see how the bone has covered this plate. So I had to actually kind of peel it off the bone on the lateral side. We'll go ahead and sort of do our initial preps. Go through our implant placement. And this is the type of bony width and height that I think will offer stability in the long term. Next is a little bit of a soft tissue augmentation, which is the next thing for this patient. So we have to pay attention not to, even though it's not an aesthetic area, the soft tissue is critical in preservation of the bone that we worked so hard to achieve in. So that's going to be a connective tissue graft to augment that, and maybe a minor vestibuloplasty. How about a vertical defect using another technique, sinus lift and a GBR technique? Here's a patient that presented with a type 4B periimplantitis, loss of tissue, loss of bone. And this was a case that we can see clearly loss of bone and both width and height. And the implants are removed. Probably nowadays, I probably will do this in a two-stage process. I was a little bit of a, trying to be a little bit heroic that day and did everything in one day. But I've become a little bit more humbled over the years, a little bit more conservative. I've become a believer in one miracle at a time. So I did go ahead and remove these implants and grafted in the same day. But the quality of the tissue is really poor, and I think one has to be concerned about the healing process over the graft. So nowadays, I don't do this anymore. I wait for it to heal for 2 months and then go back, do our sinus lift and GBR, and now we can have a very sufficient amount of bone, but still not good, still a little bit inadequate. I was planning an offer to do another augmentation, which patient did not accept. He said, I'm done, I'd like to get my teeth. Sometimes the reality is what we have to accept. We go ahead and do our workup. And here we see we have plenty of bone. The tissue is great. We have plenty of keratinized gingiva. So now in terms of design of our incision, we can take the palatally positioned incision so we can take advantage of this very thick tissue and keratinized gingiva and push it on the lateral side, right? So we're going to do that. And here's the incision. So we can place our implants. And we can see that here is the new soft tissue, which beautifully lateralized, very thick, and very stable, and it'll provide us with a good stability in the long term. The final outcome, still a little bit more apical than I'd like to, but the patient did not agree with the plan. The next level is sort of talking about sinus and horizontal deficiencies, where I'm going to talk about a technique where it's a sinus lift and a ridge split technique. So here's a patient that presented missing 2 teeth in the back, which are planned for implants. Here's our sinus, a little bit of a septum in the sinus. We're going to be aware of that. And when we look at the lateral aspect, it's thin. Yes, you can put an implant. You can put a narrow size implant. You can probably, maybe even nowadays, I might even try to do an osteodensification and expand the bone. Maybe there are some other techniques. But at the time, not only on this one, but this one, I wanted to put a nice wider implant for stability and just didn't have the kind of bone that I wanted. So it's kind of a borderline case. One can maybe go to a more conservative treatment. But in this case, selected to do an interpositional graft. So with a flap, we're going to access the lateral aspect for a sinus lift using a rotary instrument this time, not actually a lateral window, but just kind of create an access. We're going to create our sinus lift in the anterior aspect of the sinus. And we're going to take our piezo and do our split ridge technique to prepare it for the interpositional graft. Now, if I had to do this case, I might stop and actually use our osteodensification burr to expand the bone and place the implant potentially. At the time, that was not available. So we go ahead and expand the ridge. And there are times, of course, the intention is that the lateral wall of the bone will become essentially bends out of place, but sometimes it actually breaks out of place. If it does, it is not a major deal. In fact, what we'll do is that piece will come loose, we'll put it back. So here's actually our sinus lift. Here's our sinus septum that we were talking about. Here's the anterior aspect and the posterior aspect. These are very difficult to manage, very tricky. It takes time. We'll go ahead and harvest some autogenous bone and create our bone complex. And I will take a wedge of ramus bone and essentially trim it down to create a wedge. So it's thinner at the apical aspect, a little bit wider at the coronal aspect. We can see how the sinus is intact, and that's a great test to make sure that everything is good. We'll go ahead and put the wedge in. The lateral part of the bone was actually out-fractured, which is fine. We'll proceed with our sinus lift. We'll position the wedge into positional graft in place. We'll put the bone back, and we'll go ahead and fixate it with 2 screws in a bicortical fashion. Quite stable and works quite well. And we'll go ahead and pack a particular bone into the rest of the defect, cover with our membrane, and place our PRGF and close, similar to what we described earlier. And here's our bone, here's the closure. And 6 months later, we have this level of thickness. And we augmented the area just to the point that we needed it. We didn't need to go further back, just to the anterior of where we needed to be. And here's the implant, and we can appreciate the amount of bone that we have there. This is great. This is great stability, and this is what we want. We can really position our implants now ideally, and we'll go ahead and remove our supporting screws. And complete our site preparation. And we'll go ahead and densify again. So even though there is a great amount of bone, every time I go back, I go ahead and use the densification to really kind of do the conversion that I described earlier. This really provides great stability to the implants. And I think in some of these cases, it can be certainly immediately provisionalized, especially if we have a couple of implants next to each other and splinted, it can have quite a good outcome. And this is ultimately how it was restored. And good success. The next case is sort of looking at a horizontal defect and using the onlay bone graft, another technique. There are various types of techniques available, and each one of them we have to pick based on the anatomy, based on the bone type, based on what is most feasible to achieve our objectives. So patients we had planned for 2 implants on the right side, 3 on the left, financial limitation. So we're going to look at our CBCT, and we have reasonably good bone in some areas, number 5. Number 3, thin. Number 4 is thin. We do have a little bit of a concavity here. During the workup, when we look at the, it looks like a great amount of bone until you do the wax up and you kind of do the 3D workup, and you start to see that where the implant needs to be is not where the bone is. So even though it looks great on a CBCT, it does not mean anything because ultimately we have to look at where the implant, the restoration is. So here is kind of a standard onlay bone graft, which is very difficult to do, especially when you have kind of these 3-dimensional defects with, valleys and sort of irregularities. So we have to kind of make sure that the host bed is flat so that it can really have an intimate contact between the block graft and the host bone. And the sinus lift is done, and we come back 6 months later, and we have the width, the desired, and also the height from the sinus lift. So now we can have a more ideal tissue form, bone form, to be able to plan our implants, which go through our standard wax up and placement. we can appreciate the amount of bone support that we have. And depending on where the occlusion needs to be, we have quite a bit of a room to angulate our implants. We have plenty of bone to work with. We don't have to worry about it. Surgical guide, and we'll go ahead and place our implants. And here's the thickness of the bone. And the block bone, of course, maintains itself because of the cortical nature. Of course, there is some resorption over time, but the implant helps to preserve that bone and keep it in place. Without the implant, of course, we can expect to see up to 50% bone atrophy over time, but the implant will help to preserve the dimension and then final restoration. Sinus lift and GBR technique. So sometimes we have to kind of look at our horizontal defects or maybe a combination defect and have different kind of solutions for it. Here's a patient with a hopeless tooth number 13 and 14. The tooth was extracted by her dentist, so this is when I saw her with the tooth already missing. And we have sort of a combination defect. In the number 13 area, we have this vertical, horizontal combination. Number 14, we have inadequate height of bone. And number 15, it's all gone in the crestal aspect. So we've got to now combine all the procedures that we talked about with GBR to increase the height and width, sinus lift to increase the height here, and the extraction and just a site graft here. A little bit of a combination. And here we go ahead and extract the tooth. And we can predict the sinus floor from our CBCT, so we know where the level of the osteotomy is going to be. We'll go ahead and elevate our the sinus floor, prepare our bone graft material. I want to prepare for a GBR, so I'll put some perforating holes just to help with the increased bleeding. And it's really important that when we kind of do these horizontal and vertical augmentations, we need to have a tensionless closure. So we'll go ahead and create a subperiosteal dissection, make sure the tissue is very well mobilized over the graft, and to prevent any type of dehiscence that could complicate the issue. And here's some of the icing with the inorganic bone at the top. And we'll go ahead and cover it with a membrane and a PRGF and close it primarily. And this is when we come back 6 months later. Again, a predictable restoration of the width and height in all 3 sites. And this is a site that we can easily go ahead and plan our implants and create an ideal occlusion and have the longevity and the support that I think will support our cases. And again, this type of bone is a D3, D4 bone. So I'll go ahead and again osteodensify and make sure that you can kind of see how the bone is quite soft. It kind of moves here. This is a very soft bone, but we're going to densify it inside and be able to really almost hand ratchet these implants in. They're really quite stable and have incredible stability after the bone is densified. The quality and the amount of bone and the level of it, and I think this case it could be certainly provisionalized immediately. I usually let it heal for about 3 months since it's a posterior aspect, still being a little bit cautious, and then go ahead and restore the case. Excellent bone preservation and the trajectory of the abutments, really well done. Next, I want to talk about the stage GBR. Going back to a patient that we talked about earlier with a complication. This was a patient that had sort of very, the chronic pain with his implants, periimplantitis, 2 apical in the position. And we also remember that it was perforated into the sinus. And she could not find any other reason for her complaints. So the implants were removed as she was suffering for really about 3 years with no other explanation. So once the implants were removed, her symptoms did actually improve. So what we're going to do here is the first is an explantation. Now, of course, I'm not going to talk about explantation technique. We have great explantation devices and techniques to rotate implants out very atraumatically. Unfortunately, in this case, this is one of those implants, which I've never seen, where it was a complete core implants. And I think I researched and I found the name, and I can't tell you what it is right now, but I was ready to take my reverse torque device, and I told her that this is going to take 5 minutes each. And I was a little surprised. So this is a unique case. So what do we do? Well, this is how the implants look. Some particular graph from, this is probably a 15-year case when these implants were done. And this is the bone that was on the outer aspect and the dehiscence. So this is about a 15-year tissue presentation. So the implants were removed by the explantation. Unfortunately, I had to do what I don't like to do, and that's using the Turfine burr, but there's no other option in this case. And right away, we see that there is sinus perforation. We knew that. Of course, we predicted it from our CBCT. So we're going to do a side graft in GBR. We're going to place our implant at the apical aspect. We're going to block the perforation and use some great sticky bone and pack it into the site. And covered with the membrane, and also PRGF and close up in a tensionless fashion. Because of the lack of vestibule and very tight tissue, as you notice, there was really no tissue. There's a lot of undermining, a lot of flap advancement that needs to happen in order to be able to close these, and that's how it was closed. And this is the patient in about 4 months after the surgery. Really the concern was whether or not we can kind of keep this tissue closed over the graft. Luckily it worked out. It did not get dehisced, but we have there was a huge amount of tissue deficiency from the get-go. And this is a kind of a defect that we have at this point. So can we put an implant at this point? I think we have enough bone for the implant, but it's just still too high up, still too apical. The tissue is still not ideal. So we discussed about, would it be possible, and here's our implant or the bone width. D4, D3, relatively good width, relatively good height, very much can be done. But can we go ahead and push the envelope a little bit and get a little bit more bone there? Will that affect the outcome? She was agreeable to doing a second GBR. And for this, I'm using more and more a technique called the sausage technique, which basically we can use our GBR bone complex and use our resorbable membrane with screw tacks. We put some perforating membranes, take our sticky bone, and pack it into the area, trying to achieve additional amount of bone in the vertical and horizontal aspect. And we're going to tighten this membrane over to the palatal aspect and secure it with a tack. And then we're going to pack some more bone inside, and hence this is a technique that the sausage technique that has been described to stabilize and create a space with the bone underneath. We'll go ahead and release the tissue some more. We'll place our PRF membrane over to maximize on the soft tissue healing and let that heal. This is about a month later with some enhancement, and this case is still being followed. So I just wanted to demonstrate the idea of using the sausage technique, which is one of my maybe more frequently used techniques in ridge augmentation. In the next 5 minutes, I'm going to finish with the impact of sinus pathology on our treatment plan. There are 3 conditions that I have seen that's going to impact our treatment on posterior maxilla. The first is the chronic sinusitis. Patients who present to us with chronic sinusitis and they need a sinus lift. It's an issue. It's a problem, potentially, because I think there are some risk factors that we have to be aware of with patients who have sinusitis. Perforation due to atrophic and abscent membrane, infection from a bacterial contamination, fluid stagnation, and also exacerbation of sinusitis, and of course the contamination of the graft and failure. So we have already a sinus membrane that's probably atrophied with flora. So this is not an ideal environment to try to do a sinus lift and have an uneventful case. So I think it's important that we treat the sinusitis before we do the sinus lift. The treatment, I work with my ENT colleagues to help me on this, antibiotic therapy, decongestants, nasal sprays, and maybe a surgical intervention by them if necessary to clean up the sinusitis. And sometimes it takes 12 months to 18 months to do this. This patient, in fact, we had to just wait for 12 months. And just by non-surgical medical therapy, the sinusitis was cleared up. It's very tempting to want to do the procedure when the patient comes. It's very tough to hold back and wait for a year, but that's what we must do. So in 12 months later, the non-surgical medical therapy quite worked well. Conventional sinus lift, horizontal ridge augmentation. Now we can have really a good, predictable outcome with our augmentation and be able to finish the case predictably. The next case is when we have pathology in terms of odontogenic cyst. This is a very severe form of the OKC that I saw in this patient. And of course, once it was biopsied, we needed to extract the teeth and needed to graft. The problem is that there's basically no separation. There is no wall of bone between this area and the rest of the sinus. So any kind of grafting is going to be basically not being able to be contained. So it would be very difficult, impossible to accomplish that. So this is where I think it's important to do a decreased size of the cyst with a technique that I'll show you. Achieve a bone barrier. We want to have some natural bone that can develop there so we can, when we do the grafting, we can contain it. And that's where the decompression and marsupialization technique that I've used quite often, especially in very large cysts. It can be used in certainly a mandibular, but in the maxilla as well. And here we're going to basically place a tube into the sinus, into the cyst, into the cystic cavity, and just ligate it with a wire, because we're going to keep that in there for a good 8 months potentially, 6 months to 12 months, so we don't want it to come out. And through the decompression process, and I think it's a little bit light here so you can't see the tube is sitting here right in the sinus area. And 8 months later, we can see that the sinus, or the cyst, the OKC, is gradually decreasing in size. So now we can see that by itself, it developed a bone barrier. And now we can predictably go ahead, extract our teeth, and sinus, and do the GBR grafting to address this cyst, and go ahead and place our implants. So again, it's important to kind of contain the bone graft in the area, and this is a great technique to do that. Finally, I want to talk about antral pseudocyst. This is something that we see quite often. Usually when you take a Panorex or a CBCT, the patient sort of shows this dome-shaped radio-opaque area, which is not sinusitis, because that would be more fluid-filled, kind of obliterating the entire sinus. And this is a kind of a focal inflammatory exudate that lifts the epithelial lining of the sinus and the periosteum from the bone and produces this dome-like appearance. So the question is, if we have that, what do we do about it? Do we leave it intact, or can we still do the sinus lift in place? And that's really the question. Do we aspirate it, or do we leave it intact and proceed with that sinus lift? And there was a study done by Delibasi, who looked at a number of articles that have dealt with presence of pseudocysts in a series, and basically noted that the pseudocysts in the thickened sinus membrane are not necessarily a contraindication to sinus lift. We can do our sinus lift with it in present, and the sinus lift can be done with it being intact. Having said that, this was one of the first cases that I did that I felt, decided to aspirate it, not knowing what the outcome may be. So the sinus lift was done, and using here's a membrane, and using a very small bore syringe. I'll show you that. So once the elevated, just inserting it, and this is kind of what the content of the pseudocyst looks like. So in my mind, I deflated it. I removed the fluid. I'm not sure exactly what that did, but felt that maybe that might reduce at least the contamination of where the content may be to the sinus area. And we proceeded with the final placement of the bone graft in GBR and packed and come back 6 months later. And we got a pretty good area of lift. A defect in here, whether or not that was the result of the pseudocyst or whether or not that was the result of me not elevating adequately in the medial side because I was concerned about the pseudocyst popping, right? So that may be the result of that, I'm not 100% sure. Nevertheless, adequate bone to put in our implant. Nowadays, I would go ahead and do an osteodensification and raise that area a little bit further higher and put that and not worry about that. So really, in conclusion, I want to kind of point out a few things that kind of goes back to what our objectives were. I think in conclusion, I think it's really important for longevity of our cases and what patients expect to restore the bone and soft tissue to its optimal stage and ideal implant position and restoration design. It can be done. It's not easy. Sometimes it takes multiple stages, but I think we're looking at the investment of the time and the money that the patients make, and I think the longevity of the cases deserve that. Improving the bone and soft tissue quality by conversion and grafting techniques, selecting and placing the implants ideally using 3D planning, and I think we heard a lot about the digital world and surgical guides, which is exciting indeed. And I think there is no shortcuts to predictability and longevity of our cases. This is what patients want, and they understand it, and we have to abide by it. Thank you very much. I appreciate your time.